Bismillah wa sallam ala Rasulullah. I would like to thank the organizing committee and welcome back to the third session. I would like to start by introducing myself. I'm Dr. Rula Al-Mufti, medical oncologist, consultant in Princess Noura Oncology Center, National Guard Hospital in Jeddah. I'm an associate professor in King Saud bin Abdulaziz University for Health Sciences. I'll be co-chairing with Dr. Amal Al-Bayhani. She's a consultant adult hematology and BMT and the acting chairman of the Department of Medicine in King Faisal Specialist Hospital, Medina. I will start by welcoming our first guest. Our first guest is Professor Stefano Luminari. He is a professor of medical oncology in the University and Hematology in the University of Modena and Reggio Emilia, and the head of the Unit of Clinical Research in Oncology Hematology at the Hematology Division in AUSL IRCC Reggio Emilia in Italy. He is the chair of Indolent Lymphoma Committee of Fonziani Italiana Linfomi. I don't know if it's right. And he is the legal representative of the European Committee of International Extranodal Lymphoma Study Group and the associate editor of Italian edition of Blood. Professor Luminari, please go ahead and start with your first presentation.
Thank you for the nice introduction. I'm now sharing the screen. Okay, I hope you can see it. So thank you for the nice introduction and for the very kind invitation. It's my second time in Saudi Arabia, the first virtual. The previous one was actually in person, and I enjoyed very much staying with you. Hopefully the next time. In my first talk today, I will provide you with an update of the content about indolent lymphomas that have been presented as oral presentation during the last ICML. There are 4 selected abstracts that were all presented as oral that you can see here. So the first paper is entitled Direct Acting Antivirus as Primary Treatment for Hepatitis C Virus-Associated Indolent Neonatal Lymphoma, the so-called BART study by the Fondazione Italiana that was presented by Dr. Merli from Italy. The rationale behind this study was mainly the strong and very well-known association between hepatitis C virus infection and a wide spectrum of B-cell lymphoproliferative disease, mainly including indolent lymphomas and mainly including marginal zone lymphomas. Apart from the epidemiological data, some interesting findings come from the acknowledgement and recognition that interferon-based antiviral therapy that was considered in past for the treatment of hepatitis C virus was also associated with response and not only with ACV eradication, so with lymphoma response. But in that case, the antiproliferative effect of interferon could have not be ruled out, so there is no clear role of the activity of more direct antiviral agents and their potential role as also therapeutic agents for the lymphomas. This has been addressed by some retrospective study, and this BART study is the first prospective, even if small study, that as a phase 2 study mainly included adult patients with any of the indolent lymphoma subtypes, not only including marginal zone lymphoma, but also considering lymphoplasmacytic, small lymphocytic, and follicular lymphomas. All the patients had to be HCV positive of any genotype. And for all the patients, the requirement was the lack of criteria to start immediate treatment, and shown in the box in the lower right part of this slide. The primary study was based on the assessment on definition of virological response, and the clinical response of lymphoma was included as a secondary endpoints in terms of overall response rate, but also in terms of efficacy assessing progression-free survival and duration of response. The treatment with antiviral agent was based on direct antiviral agents like ledipasvir and sofosbuvir or velpatasvir. The treatment was had to be prescribed according to the genotype, and the change in the treatment was based on the genotype and on the drugs that were used and on the duration of the treatment that was at different duration from 1 year or up to 2 years for the other genotypes to eradicate. These are the results of the study. 40 cases were included with 27 patients of the marginal zone subtype, including 6 splenic, 7 nodal, and 14 extranodal cases, and with other indolent lymphomas differently represented with the small numbers per single subtype. The median age was 68 years. As you can see, all the genotypes were represented, with genotype 1 and 2 for HCV being the most frequently represented, respectively in 16 and 28 cases. 11 cases also were positive for hepatitis B antibody, and some cases also concomitant problems associated with HCV infection like cryoglobulinemia. And in terms of the primary study endpoint, there was virological response. This was achieved in 100% of the patient, with most of the patients achieving also a very rapid virological response. 92% were already negative for HCV RNA detection after 4 weeks of treatment. And what also it was more important for us hematologists is the description of the clinical responses that were observed in 18% of the patients, thus defining an overall response rate of 45% of the patient. That was quite consistent among the different subtypes. Marginal zone lymphoma had an overall response rate of 48%. Non-marginal, the response rate was 38%. Difficult to say this different, but across the different marginal zone subtypes, the overall response rates ranged from 71%, the highest value observed in multiple lymphomas, to 43% in nodal marginal zone lymphoma, and to, I would say, an unexpected 0% overall response rate in splenic marginal zone lymphomas. Nevertheless, if you look, if you move from the definition of clear-cut response class, but if you look at tumor size reduction, you can see that most of the patient, 2 out of 3 thirds of the patient achieved some kind of size reduction that were observed in terms of nodal responses, 38%, extranodal responses, 71% of the patient with extranodal did achieve a kind of a response that was complete in 43%, splenic response that was observed in 30% of the patients. And in terms of the duration of response, of course, these are a very small group of patients, but you can see a duration of response that is at 3 years, 83%, so very encouraging. The second study is the ISG38 study. There is a phase 2 trial of rituximab plus Corambus plus followed by 2-year rituximab maintenance in multiple lymphoma patients. This study was presented by Dr. Pirosa from Bellinzona. The rationale behind the study is the experience, the huge experience achieved by the ISG group with the ISG19 that defined in a randomized fashion rituximab plus Corambus without maintenance as the standard treatment option for multiple lymphomas. The study also allowed to define the multi-IPI prognostic scores and also allowed to validate the concept of POD24 in this patient population. But for what is related to this presentation, the new ISG38 study tried to move over from this first finding to mainly to assess the role and the activity of subcutaneous rituximab, also in multiple lymphomas, and also to evaluate, even if not in randomized fashion, the role of maintenance in multiple lymphomas. This is the design of the study. Similar to the ISG19, chlorambucil was prescribed in 2 steps, as well as the rituximab. Part A was chlorambucil daily for 6 weeks, combined with 4 weekly doses of rituximab, standard doses. The part B consisted of 4 monthly cycles of chlorambucil given for 14 days, associated with rituximab subcutaneous given at day 1 of each month, and followed by a part C that was maintenance with rituximab subcutaneous administered for 2 years in 2 months interval. The primary endpoint of the study was CR rate, but secondary endpoint also included overall response rate and duration of response and safety. 111 and 12 patients were enrolled. The median age was 65, 63% at an advanced stage, and the MALT IPI index was intermediate high in 71%. As you can see, most of the extranodal sites were represented as expected. Stomach was the most frequent extranodal site, being involved in 32% of cases, followed by the lung in 14% of cases, and other extranodal sites. The primary study endpoint, the results of the primary study endpoint, the CR rate is shown here. There was an overall 67% of CR observed in the long-term follow-up, with an increasing trend of CR rates that started to accumulate from the first time point. There was 6 months at the end of induction, and increasing at 18 months, and then the end of maintenance 67 months, suggesting that a kind of role of maintenance can be supposed in this setting. And this is the survival curve of the ISG 38 study, with a 5-year progression-free survival of 86%. And even if this is not a randomized comparison, it can be unfair for some of you. The comparison between the ISG 38 study that included maintenance with the previous ISG 19 study that did not include maintenance clearly show that there is any kind of improvement of as a consequence of maintenance is probably suggested here. So the third study is a study that I was able to present in the oral session. It is a response-adapted post-induction therapy in follicular lymphoma with updated results of the FOL12 randomized trial by the Fondazione Italiana Linfomi. Mainly what the study tried to assess, I would say for the first time, is the hypothesis that using the quality of response defined with the PET and with molecular assessment could be used to decide about a different approach in patients responding to standard induction therapy. Looking at the study design, all patients with follicular lymphoma stage 2 to 4 and in need of therapy due to a high tumor burden had to receive a standard induction therapy, and then they were randomized to receive a standard approach that was rituximab maintenance for all patients regardless of the response. And conversely, in the experimental arm, patients had to be evaluated for the quality of their response to induction therapy, and the patient achieving a complete metabolic response that was defined by Deauville 1 to 3 at PET done at the end of induction. These patients were also evaluated for molecular assessment that mainly targeted T14/18 translocation with the NRQ PCR technique. In the patient with double negative, that is both metabolic and molecular negative, they were not treated with maintenance, but they were only observed. If a patient with complete metabolic response turned from a negative to a positive molecular status, this patient had to receive a weekly rituximab until negativity of the molecular marker was achieved, with the main aim here to try to delay and to avoid clinical progression that was anticipated by molecular relapse. And last, the non-complete metabolic response patient had to receive standard maintenance with rituximab after 1 single dose of radioimmunotherapy that was delivered with Zevalin. Patients with less than PR at the end of induction were sent off study and were managed out of the protocol. And looking at the results of the study was a non-inferiority trial that was designed with a hypothesis that the standard approach of a response-adapted post-induction management was non-inferior in terms of PFS compared to the standard maintenance therapy. This hypothesis was not achieved, and as you can see here from the first slide, as a first point, we were able to show that both molecular and metabolic response were prognostic, even if they were able to identify a small proportion of patients at high risk. 9.3% of the patients did not achieve a metabolic response, left panel, and 10.1% of the patients were not able to achieve a molecular response. And this patient had a worse progression-free survival compared to patients that achieved a complete metabolic and molecular response. But this is the results of the study that clearly showed that the hypothesis of non-inferiority between the two study arms was not achieved. Actually, patients treated with the experimental approach that mainly was represented by no maintenance had a worse progression-free survival compared to patients that received standard maintenance. That tells us that even if achieving a complete metabolic and molecular response is a good news, if you believe that PFS is a good clinical endpoint for the patient, you still need to prescribe and to administer standard maintenance to the patient. Luckily enough, even if the study was not powered to identify difference in overall survival, the randomized arm was not associated with a difference in the risk of death for the patient. And moving to the subgroup of the patient, we looked at the study results by randomized arm according to metabolic response. You can see here only patients achieving a complete metabolic response, that in this group, the main results of the study were confirmed, 628 patients. And the main study results were also confirmed in patients with the double negative molecular and metabolic response as shown in the left panel. In the right panel, you can see the survival of the patient who were complete metabolic response, but for whom the molecular analysis of response turned out to be positive. So the red curve represented the patient that even if they achieved the metabolic response, they had to receive weekly rituximab due to a positivization of the molecular marker during the follow-up. As you can see here, this preventive measure that was adopted in the study was not able to change and to modify the risk of progression. It was still poorer and worse compared to the outcome of the patient randomized in the standard arm. So finally, this study was basically the first study that addressed the response-adapted approach to follicular lymphoma patient, and was basically an indirect confirmation of the role of rituximab maintenance for patients who responded. This is one step back in the research of a treatment personalization of follicular lymphoma, but there is a lot to learn from this study, and more data will be required from this study to understand the real role of treatment personalization and risk-adapted therapy in follicular lymphoma patients. And there's a complementary slide, a complementary analysis, as this is an indirect comparison, an indirect demonstration of the prognostic role and the efficacy of maintenance. Maintenance rituximab was basically confirmed in providing better progression-free survival after R-CHOP, and for the first time, even if not randomized, but in a prospective fashion, it was also confirmed after bendamustine rituximab, as shown in the right side of this slide. And last study that was presented was the immune priming with nivolumab, followed by nivolumab and rituximab in the first-line therapy of follicular lymphomas. This is a phase 2 study presented by Elizabeth Hawkes from Australia. I have to say that there are preliminary data about the use of checkpoint inhibitors in follicular lymphomas. There is one promising study of a combination of pembrolizumab and rituximab in relapsed refractory patients that was presented by colleagues from the MD Anderson with promising results, but more recent data about one single agent study of nivolumab in relapsed refractory follicular lymphoma patient was able to confirm that the nivolumab, so the checkpoint inhibition in follicular lymphomas, all comers, is a good strategy to achieve clinically significant responses and efficacy of the treatment. Nevertheless, this is a phase 2 study that for the first line approach of the patient with treatment-naive follicular lymphoma patient requiring therapy, started with the nivolumab single agent for 4 cycles, and then continued with nivolumab alone for a patient who achieved a complete response after the first induction phase. For patients that were not able to achieve a complete response, nivolumab was combined with rituximab to complete the induction phase of treatment and to continue with the post-induction maintenance phase for 12 weekly, for standard maintenance for 2 months, for up to 2 years, and nivolumab for 12 cycles, with a total of 18 cycles in the maintenance phase. The primary endpoint in this study was safety, assuming a risk of grade 3 or more toxicity less than 70% during the induction phase, and secondary endpoint were other safety endpoints and response rate, progression-free survival, and overall survival. 39 patients were enrolled in the study. Median age was 54 years. Advanced stage was observed in almost all patients, with 67%, 2 out of 3 patients with a stage 4. B symptoms were present in 23% of the patients, and bulky disease in 23% of the patients. The FLIPI, the final risk was intermediate, high in 56% and 18% of the patients, respectively. Out of the 39 enrolled patients, all the 39 started priming with rituximab for 4 weekly rituximab. 2 had to discontinue due to progressive disease. 2 patients achieved a CR and continued with nivolumab, a single agent, for the duration of the study. Other 35 patients added rituximab to nivolumab treatment and continued up to the maintenance phase. And overall, 26 patients were able to complete the treatment and started follow-up. Safety was the primary endpoint, and as depicted here, the primary endpoint of safety was met with only 16 patients, that is 41%, experiencing grade 3 or higher toxicity during induction. Overall, the safety profile of the combination of the nivolumab and of the combination of nivolumab and rituximab was quite well tolerated, with 13% of infection and with other grade 3 or higher events that are shown here that occurred sporadically in the patients. And regarding the immune-related adverse events, some of them were observed during treatment or at the end of induction after the stop of nivolumab. There were some grade 3 rash, grade 3 pancreatitis and hepatitis, and as well as some laboratory alteration as shown here. But overall, this is confirmed as a manageable and safe combination. And my last slide, just to remind the final results of the study in terms of the secondary endpoint response rate. Response was overall observed in 92% of the patient, with 22 patients, 56%, who were able to achieve a CR after the full program. Interestingly, 2 patients were able to achieve a complete response after nivolumab priming and were able to maintain the complete response during induction and maintenance, suggesting that even if checkpoint inhibition is not a treatment that should be considered for all comers follicular lymphomas, at least a group of patients with follicular lymphoma may benefit from the use of this therapeutic approach. The problem here is to identify with the biomarker who is the patient who is going to benefit from the treatment, and to address the treatment to a more specific subset of patients with a more rational approach. With this, I would like to thank you for your attention, and I completed the overall overview of the indolent lymphoma oral abstract at ICML. Thank you very much.
Thank you, Professor Luminari, for this very elegant presentation. I don't have any questions, but I was wondering, in our practice in Princess Noor Oncology Center, we actually used to give maintenance rituximab after BR. It is our practice even before the full 12 final results. So I was wondering, in your practice, were you doing that as well?
Yes. Yes. So we were the first to show in a prospective way the role of rituximab maintenance, but we were not the first to suggest the role of maintenance after RBR. So there were also already convincing data and that were in favor of an efficacy of rituximab maintenance after this approach. We do prescribe rituximab maintenance and anti-CD20 maintenance after beta-based immunochemotherapy. We only stopped and reduced the number of prescription because of the COVID pandemic, because we consider enough to complete a good induction and achieving a CR, and we consider too high the risk of severe COVID during a treatment that has the only role of prolonging PFS without any effect on the overall survival. Conversely, the risk of developing a severe COVID during rituximab therapy was real and was associated with a significant increase in the risk of dying from COVID. So only during COVID we stopped for a while the rituximab maintenance. Now that the people are vaccinated, we are starting again to prescribe maintenance.
Perfect. I think you have answered even the questions that I was going to ask. Thank you so much. I will hand to Dr. Amal Al-Bihani to present our next speaker. Thank you very much, Professor Luminari.
Thank you.